Alrighty. We're confirmed for 3 students, Ms. Witchin, Ms. Marissa, Ms. Roxana. Currently at 9 a.m. This is week 2. This is MED240 Pharmacology. Meets Thursday mornings at 9 a.m. And again, another public service announcement that if you have an on-the-ground class like this, you see like it has like a prefix like this. 7 is Thursday, D is day or morning, AX is Alexandria campus. It is mandatory that you show up to a Zoom session. Now, if you can't make it, give me a call so we can have at least like a quick meeting on Zoom, later that day or maybe the very next morning, real quick, so that I can post attendance. Okay, that's the new policy. What is due today? Of course, your discussion 1 and your quiz 1. And at least one of you was reporting that there may be a little glitch, but remember, when you're taking an exam, there's a glitch, either text me up here or my cell phone, or email me. And remember, all my information is here in announcements, right down here in professor contact information. Okay, so let's get on with the show. This is week 2. And let's see what's cooking. So for this week, we have to talk about how do we dispense medication. So if you look at this, the way we dispense medication, there has to be an order. Okay. Then the physician or the DNP or the DO, doctorate of osteopathy, is just like an MD. There has to be a medication order, and that's what a prescription is. And if you remember your medical terminology, script means to write, pre means before. So before you can dispense any medication, there has to be an order. Now the order could come in paper, the order can come electronically, it could come via the phone, and it could become verbally. So if it's by the phone or verbally, automatically go into the chart, whether it be electronic or whether it be a paper chart, and write down what exactly was said to you. Okay. And especially as a medical assistant, one of their biggest jobs is confirming the prescription to the pharmacy, because there are times, like as you could see here, like in these little examples, it's chicken scratch. But nowadays, a lot of doctors have all scripts, and all scripts is electronic. So, and that's usually hooked up with their electronic medical records. So it should be clear. But what may not be clear is maybe generic versus, those of you who did reply, that in general, yes, there's no real difference between generic and the brand, but there are differences regarding payment. So many times, certain insurances and certain payment plans require that it has to be generic. Okay. But there's little itty bitty differences, and you guys kind of know that. It's between, when you go to the dollar store and you buy cola, it's essentially the same thing, but it's not as good as, if you buy Coke or Pepsi. There's little variations on the theme, but all intents and purposes for most medication, there's no real differences. That's what I got from the majority of your replies. So good on you. And here's another side note regarding your citations. Most of you did rather well, but try not to pick the very first one. All of you, I think, picked the same one, FDA.gov. All well and good, but look a little further. Look, there's actually an exercise in graduate school where you're not allowed to pick the first 10 citations. You gotta, dig deeper and look towards alternative yet legitimate resources. So let's look at the parts of prescription. Of course, your has to have your patient's full name. Now, your patient's full name as it appears on their insurance card. Okay. If there's an error in the insurance card, spell it the same way as the insurance card. Okay. Because if not, it won't get paid. Of course, there has to be date on the prescription. Now, you have the thing called the inscription, okay? It's the body of the prescription, and the inscription provides the drug name, dose, dosage form, and quantity. And by dosage form, it means like, is it liquid? Is it semi-solid? Is it colloid? And of course, the quantity, how many pills? That as a physician, how many times I forget to put the total number of pills. Now, that's the inscription. Now, the SIG, and sometimes physicians write the word SIG right next to it. That's called the transcription. Those are the directions. And many physicians either forego the SIG or they make the instructions so vague, or they say things like, look at the label and things like this, right? So this is the thing as a medical professional that you have to make sure gets properly communicated to the patient. And remember my story last week, right? I didn't even bother putting a SIG for that poor patient who took a vaginal suppository orally for a whole week. And if I wrote SIG, vaginal suppository, and just take the 2 seconds, insert using the, and she didn't know there was like this little tube thing. She's like, what's this thing for? And I'm like, I was just so embarrassed. And the nursing staff was just laughing at me. So inscription, that's the body inscription. That's the drug name, the dose, dosage form, right up here. And then the SIG is the actual directions. And many times the physician will write SIG. And if you see here, it says S, and it says BID, So remember your medical terminologies. BID means bis and DA means twice a day. TID, 3 times a day. QID, 4 times a day. PO means per orum or by mouth. That means this person has to take this Lipitor, 20 milligrams, right? And there's 30 pills here, right? Dispense, DISP, number 30. Let's see if I can enlarge that a little bit so you can see that. Right? But at home, you could probably enlarge it even better. So BID, know your, review your what do you call that? Your medical terminology abbreviations, because in this world of prescriptions, we still use abbreviations. Number of refills or no refills, that's important. The doctor has to have the signature, right? DAW, or if generic permitted, DAA number. And this is really important right here, the DEA number, especially if it's a controlled substance. Remember, if it has a controlled substance, it has the word C and then a Roman numeral next to it, and it's most likely 2, 3, or 4, right? And 2 is really, really addictive. 1 is, like heroin. We don't prescribe that, right? Or crack cocaine. And then 3 is not as bad as 2. 4 is not as bad as 3. But you have the DEA number here, okay? That number is as delicate and as dangerous as your social security number. Another number is that's not mentioned in this lecture is the UPIN, Universal Personal Identification Number. It's going to look like a social security number. The UPIN is the doctor's special social security number utilized strictly for billing. Okay, so UPIN, DEA number, these are very important numbers. Do not lose them. Do not expose them to the outside world. And many times if you have a paper prescription, the doctor stamps it with this thing called a TrueDat. Let me show you what that is. See these little stampy things? Like that? The self-inking stampy things. TrueDat is this one right here, or Trodat. My memory vague to me, right? So that is usually on a keychain attached to your doctor, or sometimes they do silly things like leave it in their drawer. If this thing's floating around in the world, it has the UPIN, it has DEA numbers, it has the very, very sensitive, and has the doctor's signature, by the way, on there as well. So please, and I forgot to mention DAW is dispense as written, okay? Or is generic permitted, okay? So know those abbreviations, and you're gonna need to know them. Now, RX, that's right here in the beginning. See this here, RX is barely visible. RX means take thou, or to take thou. That means this is a prescription. Dr. John Schultes, MD, wants the patient name here, to take this Lipitor 20 milligrams. He wants to take the patient one pill twice a day, every day, and by mouth, okay? So without that RX, there is no order, okay? So always double check, actually triple check, triple and quadruple check. How many times on a third pass I go, oh my God, that's not the right medication, or oh my God, that like the doctor wrote it the wrong way, and immediately inform the doctor of a potential error. Okay. OTC is over the counter, right? Here's some other abbreviations that are very common. Of course, AM, PM, morning, evening. AC is Antecome, which is, if any of you remember your Spanish, comer is to eat or before meals. BID, twice a day. TID, 3 times a day. QID. Now C with a little line on the top is with. S with a little line on the top is without. Cap, of course, is capsule. DAW, dispense as written. DC is discontinue. G is gram. Now, when you have stuff like this, write it out. Grams, grains, drops. I write it out, because this GTT, if the doctor has horrible handwriting, it looks like GR. This GR looks like G. Or sometimes some people think GR is grams. Grains and grams are totally different. Grain is like a tiny amount. So if my patient is supposed to take 20 grams and the pharmacy orders 20 grains, it's nothing. 20 grains is nothing compared to 20 grams. Other abbreviations, of course, hour, and Q means each. So QH is every hour. IM, intramuscular, IV, intravenous. Those of you who are in my Friday class, we're going to be playing around with intramuscular and intravenous, not intravenous, but intramuscular injections, simulated, of course. L, liter, microgram, or milliequivalent, MEX or milliequivalent, you could write that, but I write the whole word microgram, because again, all it takes is that C to get smudged and it looks like milligram. And if you give milligrams instead of micrograms, you now just updose your patient by 1,000%, which is not good. ML, milliliter, which is also the same thing as a CC or cubic centimeter. NKA, no known allergies. NKDA, no known drug allergies. NPO, non per orum or nothing by mouth. PC is after meals, because if AC, ante, is before, PC is post, after. PO, per orum. PRN, very common, as needed. QH, Q2H, QID, QS. I don't use QS too much. Stat is very important. If you see a stat, you better fill that order right now. And of course, anytime you fill an order, every time you do something in the chart, you date it, you sign it, and the date should have the time, AM, PM, especially if it's a stat order. If I received the stat order late, I write down when it was received and when it was carried out. If you were in my medical terminology class, week 2, week 3, one of the discussions were, are abbreviations good? Well, according to the Joint Commission on the Accreditation of Hospital Organizations, it is not. And that's why a lot of electronic medical records now, they have drop-down menus, because you could see how you know, this could look like an M. There's just so many problems. Okay, so if you have something like this, use the drop-down menus in your electronic medical records, or if it's paper, write the whole thing out, because mag sulfate looks a lot like morphine sulfate. You don't want to give morphine when you were supposed to give magnesium sulfate. You don't want to give magnesium sulfate if it was supposed to be morphine. And another big thing about prescriptions is be careful of decimals. Always have a decimal placeholder, right? So for small items like like 0.2, right? Write 0.2, okay? All right. Now, here's another big thing for your RMA and AMT, even for NCLEX. They talk about the 5 rights. You got to make sure that you give the drug to the right patient. You always verify the patient, and it's always 2 identifiers, and it's always date of birth and or the last 4 digits of their social. And if you're in your hospital, you of course verify patient identifiers with the scan of the bracelet. If there are any discrepancies, you cannot administer the drug, okay? The right drug. Always check the medication against the original prescription and the original patient's disease, okay? So if the patient's receiving cardiac medications and there's no cardiac diagnosis, ask the doctor what's going on, because the chart is incomplete. Or if you notice the patient was given cardizem for the last 4 days straight, and today was given cardiolipin without any discontinue of cardizem disorder, I mean, not disorder, cardizem order, then you have to question, is this the right drug? Right strength, okay? Be careful of this, you know, these decimals, okay? Make sure it goes, it's the right strength. The right route. Remember my story? If it's per vagina, please don't let the patient take it per orum, right? Because depending on the route, and of course, if something's supposed to be delivered via a per vagina, of course, if you swallow it, it won't work. And the right time. For example, if it's a stat, it has to be a stat. Now, here's the thing about patients. If you give an order like TID and you tell the patient 3 times a day, this is what the patient's going to do. If they miss the morning and the afternoon, they'll take all 3 pills at night. You have to specifically tell them, especially if it's TID, you have to tell them, when the first time you wake up, you take a pill. At lunchtime, you take a pill. And right before you go to sleep, you take a pill. If you skip, don't double up on the pills. This is the kind of instructions that you have to be explicit, because I can tell you right now, the DNP or the doctor will not have time to be that specific. But you, knowing your medical terminology, you knowing how to read the prescription and to read the chart, you have to inform them that way. And especially with your geriatric patient, there's polypharmacy. My father, when he was alive, had 12 to 14 medications daily. And it was very, very hard to track, right? And it was very, very easy for him to forget and miss. Another big thing that the FDA has a thing about is labeling, proper medication labeling. So please inform your patient not to take the pills out of the bottle that it was dispensed in, because we need to know what's what. How many times I've had patients, they put all their pills in one bottle so they don't forget it. And then we don't know what's what, okay? Because if you look at this, there are important information on here. It has in bold right here, it has the proprietary name or the brand name. In parentheses, it has the generic. It has here the dose, which is 100 milli, what is this? Is tablets. So it's 100 milligram per 1,000, and that's a tablet. And sometimes now the labels have a picture on what it looks like. Okay. Here's another one, 500 milligram tablets, and it's an approximate sodium. Okay. What else would it have? It'll have little instructions here, like when to store it, where to store it. Some of the medications are heat sensitive. Okay. Here's a stock bottle. So this has a total of 75 ml or 75 cc's total when it's full. This is augmentin, amoxicillin, which is a antibiotic, right? And it's a combo, amoxicillin and clavulanic acid potassium. And in it, the strength is for every 5 cc's or 5 ml, there's 125 milligrams of the drug. So in the week, in like week 7 and 8 and whatnot, I'll be asking, let's say you want to deliver 250 milligrams. Well, how many cc's will you be giving our patient? If it's 250, you could be giving them 10 cc's. If I only want 125 milligrams, you'll only be giving the patient 5 ml or 5 cc's. And let's see, directions. Now, sometimes, remember your anatomy and physiology when we talked about the different kinds of solutions, colloids and suspensions? Look for the directions for mixing because sometimes they want you to shake it up, okay? Like this one. Tap the bottle and then until all powder flows freely at approximately 2/3 of total water for reconstitution. So these are important. These are important things that are going on. I'm watching, okay? Dosage forms and routes of administration. Now, here are 5, A, B, C, D, E. So it could be oral, right? Per mouth. It could be nasal, like a, you know, they put it in their nose and they snort it up their nose, like this little inhaler thing. And well, this is not really an inhaler. You put it like in your nose and you sniff it all up. And then C is pulmonary, right? You have this inhaler here. Subcutaneous, that's an injection, or transdermal, and that's a patch. And it has to go on certain parts of your skin, okay? So you got to know what these routes mean. So I could have a picture and do this, A, B, C, D, E, don't you think? Oral, parenteral, topical, right? Oral, of course, mouth. Now, oral medications are done by mouth. That means it has to go, you eat it, it has to go down your esophagus, and then it has to be processed with the liver. That is called first pass effect. That's why oral takes forever and a day for it to start reacting. But parenteral injection, that's going to happen almost immediately, okay? And that's why you got to be very careful before administering injections, okay? Because if you have side effects or you have bad things that are going to happen, they're going to happen pretty darn quick. But no matter what you give, you always monitor, you always have the patient monitor and call us immediately if there's any issues. Other forms of per orum is a sublingual. That means it has to be underneath the tongue. A classic example of that is nitroglycerin tablets for angina or chest pain. Buccal, that dissolves in the cheek. That means you got to put it between your tongue and your cheek, and it has to dissolve that way. You don't want the patient to swallow it because it releases a lot slower. Okay. Oh, and I mentioned that. Right? Disadvantage of oral, it's slow. There's a first pass effect. That means it has to go through the liver, right? But again, it's convenient, self-administered, right? It's nice. But parenteral, that's intramuscular, IV, and intradermal. That's going in an injection. It's going in your skin. The really neat thing is it's fast. The bad thing is that if there's any problems like infection or adverse reactions, because remember, any drug can give you an adverse reaction, then there's going to be bad news and it's going to happen quickly. That's why part of the protocol is that after you administer the medication, you wait a little bit and you watch the patient and you watch the site of injection, okay? Topical, right, is applied to the skin, okay? You also have ophthalmic, we put it in the eye. Otic, we have eardrops. Nose, it could be that little nasal stick that we put up there. Of course, rectal, I put a suppository in your rectum and or in your vaginal canal. Okay, topical creams, it could be cream, gel, suppository. So this is all topical. And topical, if you remember tope in your medical terminology, it means area. So it will work locally within the area that, that the medication touched. Okay. So one of the factors that we already talked about is first pass effect. How is the digestive system of your patient? Okay. Other factors are, how old are they? Metabolism in children is very fast. Sometimes they metabolize and change the drug so fast that the drug doesn't have time to work. Elderly, the exact opposite. They don't metabolize the drug. It sits there forever and it's hard to remove. And that's a potential for an overdose. Okay. There's, of course, we mentioned allergic response. Remember, your body has immune defense. Any outside material, especially outside chemical that the body doesn't recognize as itself, will fight it. Now, remember we talked about your enzymes and all that stuff, especially in the liver. There's these enzymes and there's these chemical processes, and one of them you may have heard of, cytochrome P450. Well, there are some people metabolize things faster than others or metabolize things differently than others. For example, have you ever met any Asians who are not allowed to drink because if they drink any alcohol, they turn bright red? My friend Tony, he loves alcohol, but he can't drink it because he gets like hot flashes. If he takes even just a sip of beer, he turns like beet red. And it's because his genetics, he has a mix of genetics from Korea and the Philippines. And many Asians are missing that enzyme to process alcohol. And then that's why he turns like beet red and has a significant immune response. That's why I love giving him beer. It just entertained me. So he turns like bright red, like a beet. It's funny. Special indication considerations for the elderly. Remember, number one is the polypharmacy. The best bet is to take a piece of like lined paper and then take a ruler and just write everything down. Another thing that I used to do for my father was I took pictures and then I copied and pasted it onto the little chart I used to make him, and it gave times of the day and which colored pill. Another thing you could do is you can go on eBay or CVS or whatever, Medicaid, Medicare should pay for it. You know those big squares that hold meds, and it has a square for like different parts of the day. You could pre-fill all of that out and just tell your patient on these days you have to open up the blue boxes. At these times you have to open up the yellow boxes. Between that and a chart, that's really that'll really help with the polypharmacy and really help with the cross interaction. And that's also another issue. The more meds you take, the more chance that the medication will start interfering with each other. Okay. And of course, when you get older, how's your metabolism? Meta, change, bole, growth. When I was young, I remember I had to gain a pound for a wrestling meet. I was 16. I ate 2 Big Macs and then it didn't bother me. I did the wrestling meet and then ate another Big Mac on the way out of the gym. Now I eat 1 Big Mac, I need a nap. And I'll be discombobulated for the next 3 hours because I'm much older. My metabolism is different. All of these things are different, visual and auditory. So if my patient can't open the bottle or if my patient can't read the label, you really need to help them. Another thing I used to do is take the label and put it in the Xerox machine and blow it up for my patient so that, they could read it a little bit better. Or whoever's the caregiver of the patient, you give them the specific instructions. Okay. So remember what we talked about, pharmacodynamics and pharmacokinetics, right? Remember pharmacokinetics, what your body does to the drug. So when you're older or when you're very, very young, you have different absorption, different distribution, different metabolism, and different elimination issues, right? And because and also, it also depends on the patient. There are some patients that it's faster, some patients slower. Another big thing is protein binding. We all know we have floating around proteins in our plasma. And sometimes chemically, since they kind of get attracted to the chemistry of the drug, it binds with it. So that traps the drug in the blood longer. And if the drug is in the body a lot longer or doesn't get eliminated properly, then there could be a distribution issue. It's not going to get to go where it is, and there's going to be a definite excretion issue. You won't be able to get rid of it in the time allotted, and then that, again, another potential for overdose. Common adverse reactions, you've heard them all, right? And you even heard, those funny commercials, may result in death. And it's funny for the commercial, but not funny for our patient. Let's talk about anticholinergic effects. If you recall your anatomy and physiology, I think I mentioned it briefly when we talked anatomy and physiology 2 on the chart that we talked about neurotransmitters. One of the neurotransmitters we have is acetylcholine, right? And it's very big on blood pressure and urinary. And we already know that blood pressure and urinary, they're best friends, and they're related to each other, because the more you pee out, your blood pressure could drop. The more salt you retain, your blood pressure will go up. Well, anticholinergics, right? Anti means block, will block the actions of acetylcholine. The problem is you get these anticholinergic effects, okay? You get confused, blurred vision, you get constipated, dry mouth, lightheaded, and then you got some issues with urination. Now, doesn't that sound a little bit about, remember, your sympathetic and the parasympathetic? It's kind of messing with that same thing. So just know that some medications have anticholinergic effects, and it's not good. And these are the things that you got to warn your patient about, okay? Because just imagine one day you're waking up, you don't know where you are, you can't see straight, all right? You haven't pooped in 4 days, and you feel super dehydrated, and no one told you, you'd freak out. Age, now, regarding dosage, the big thing, especially with children, is their weight, okay? Age, not so much, because we're looking at either body surface area or BMI, body mass index, right? So that's why in pediatrics office, just like obstetrics, we're constantly weighing our patient. And the weight determines the dose. I don't have to go over active versus passive immunity. You should know that from anatomy and physiology 2. I just lectured that last night, right? So you can review that little part. Immunization schedules, they're a little bit different. They change from year to year, but these are pretty, I believe Dr. Cisco updated these, so they should be good. Now, allergic response, you know what they are. They're signs and symptoms. They're 5 of the cardinal signs and symptoms of inflammation. So all of this stuff, right? And remember the chemical in your body that signals this. It's histamine. So if you have an allergy, what do we give our patient? Antihistamines. We block the histamine, therefore blocking the inflammation or the adverse effects of inflammation. Okay? Now, what's the difference between a side effect and an allergy? Side effects are caused by the drug's metabolism, pharmacokinetics, and absorption and whatnot. But the allergy is an immune response. Okay? So for example, right? Side effect for aspirin or ASA, which is salicylic acid, right? Since aspirin is salicylic acid and I eat it, right? It goes in my stomach, combined with all the acid that's in there, of course I'm going to have stomach cramping and stomach pain. That is a side effect. But goes, if I have, if I start getting beet red and then I can't breathe and then I break out in all these rashes, that is an immune response to aspirin. And that is called Raynaud's syndrome, and it's rare. And it's probably the only true dermatologic emergency. So remember, allergy, think immune response or inappropriate immune response. And drug reaction, think that we kind of knew it was going to happen because we knew the mechanism of action, or we knew the pharmacokinetics, or what the drug was made out of. And aspirin is definitely an acid. That's why a lot of people like naproxen or NSAIDs, which are non-steroidal anti-inflammatory drugs like Tylenol, also known as acetaminophen, because it's not acidic and won't cause stomach discomfort. That's why in the last 30, 40 years, less and less people are taking aspirin. Now, a neat side effect of aspirin is it acts like a little bit of a blood thinner. So if I take 81 milligrams a day and I have heart trouble and I have blood pressure trouble, then you okay there, buddy? Oh, great. Put on your pants. I got to go deal with that soon. Okay. However, it goes, so know the difference between a drug reaction, or a side effect, which is kind of expected, and the allergy. Allergy is unexpected, and it is an immune response, an unwanted immune response. Okay, we already mentioned this. Non-compliance. Again, back to your geriatric patient. The more meds you have, the more likely your patient's not going to take all of them. And also, the more side effects you have, the more your patient you don't communicate with your patient, okay? Or if there's any mental disease or defect that you also should know, because older patient, right, could be early onset dementia. So these things would promote non-compliance, or your patient's inability to take the medication. For most of the patients, it's usually side effects. They don't like it, so they're like, I don't like it, I'm not going to take it. They're all right with being sick versus, and many times I totally agree with them. I have some meds that I know they're helping me, but if I'm going to the bathroom every 10 minutes, it's just no bueno for me. And that's the physician's job, to try to find some sort of middle ground. Again, labeling, all the information provided for over-the-counter drugs. It's on either on the back, there's like a fact sheet, or there's a little piece of paper. Again, most people can't read it. I always refer the people back to the website. And if they're older, I'll even print out in larger form. When I was a physician, I printed it out the larger form so I could give it to their caregiver or give it to themselves. E-prescribing, that's the thing I was telling you about. All scripts is the most common here in the DMV. And it's nice because e-prescribing, there's a pharmacist, and also the DEA monitors it as well. So, and by the way, the Drug Enforcement Agency, they check every 30 days. They check daily. They check your license number every 30 days for renewal, but they check daily. And I told you the story, like I typically don't, when I was a physician, I typically don't prescribe Percocet or some hardcore pain medications. But one day I prescribed like 5 of them in a row, and I got a call from my attending saying the DEA wanted to talk to me, and I had to justify all 5 of them. All right, and they had to make sure. That's why it's very silly to me. Like when remember that doctor who killed Michael Jackson? And I could easily say that because you're a physician giving an obviously obvious person who needs help. You're just feeding him tons of drugs. That's not good, right? And that's not why we all signed on to this job. We don't just hand out pills. Now, tamper-resistant pads, but many people use e-prescribing because that's the easier way to do it. Because if I e-prescribe, all the patient has to do is just either call into the pharmacy or just go show up. It's just easier. But you could have old school My mom is one of these old school people because she's got trouble on the interwebs. She still writes this stuff out. Okay. And that's when, if there's trick and scratch or there's confusion, you most likely will get a call from the pharmacy. Now, if you can properly answer the question and it's obvious from the chart, please do so, but make sure to document who you talked to and what exactly you said. Now, if you do not understand the question that the pharmacy is giving, tell them you'll call them back at the end of business. And you gather all of the questions from all the pharmacies, and right before the doctor leaves for the day, or leaves for the shift, you ask, hey doctor, I need your answers on these. I need to call back the pharmacy at 6 o'clock or 8 o'clock or whenever you call them. All right, that's the best to do, because I used to make the mistake of like asking my physician after every patient, after every call, and he used to piss her off all day. And then when it happened to me, when my nursing staff did it to me, I'm like, I don't want to do it. He goes, I don't want to deal with that. All right, so it is, let's check attendance real quick. And just on record, there are 5 students, Ms. Wah, Ms. Roxana, oh, I forgot who Miss Pooh was. I'm sorry. Miss Marissa and Miss Witchin. I know I'll remember in a minute. Give me a minute. No, I can't remember. It's my brain is mush. But I know I'll see it when. But those are the 5 people who are at attendance today. So it is at this point of the show. Wait a minute. Let's review one more thing. So that's what's for this week, right? And if you look here at topic 2, there's dispensing medications. That's the PowerPoint we just went over. Study questions quiz, that's due next week, and discussion 2. So what are the limitations to parenterally administered drugs, right? What are the cons of giving intramuscular, intravenous, or intradermal drugs, okay? So it's at this point, I'm going to